First of all, I'd like to thank Professor Majdi Yaqub and the group for inviting me to address very elegant group of people. The other thing is, with your permission, Mr. Chairman, I've made a slight modification to my lecture. I will still emphasize on the development and the experience in Qatar for primary PCI as being the first nationwide from one national coordinating center. But I've noticed with great delight that there are few students and interns and junior in the audience, and therefore I've added few slides to make it easier for them to understand the rest of the presentation. And last, Professor Di Mario very nicely demonstrated how multinations can cooperate in the progress of primary PCI, and I'd like to demonstrate that further by being a Libyan presenting experience in Qatar, in Egypt, and in English. Okay, these are the objectives which I've just cited. It's to talk about some of the fundamental evidence-based principles in reperfusion therapy, especially in STEMI, outline the Qatar National Primary PCI Program as a clinical and research program that's nationwide, but also emphasize some of the important time intervals that we need to meet like everybody else in primary PCI, and what we have achieved and what are the programs that have we set up. In a classical slide that appears in Brunwald, the progression of atheroma goes from a normal artery to macrophages, deposition of lipids and oxidation, developments of atheroma, rupture or ulceration or other terminology for the plaque, and then either death or rehealing. Now, that's not an inevitable process because the people can stay normal all their life. They can have atheroma without an infarct, and also they can have an infarct, survive or die. Now, the pathology of the plaque is paramount in what happens next. In a hard atheroma like this with a very thick cap and very stable core, angina is very prominent, but the risk of AMI is smaller. While when you have a soft core like this with a thinner cap, the eventual ulceration, rupture of the plaque, which is the culprit of MI and acute coronary syndrome, becomes evident. And in STEMI, studies have shown that the typical picture is a total occlusion of a large epicardial vessel, and that the clot, which is very important, is fibrin-rich, and thus the success of thrombolytic therapy. ST-Elevation MI is defined by ST elevation of ST segment of 2 millimeters or more, and you know the rest. The reperfusion strategies in ST-Elevation MI were typically, for a long time, pharmacological, which is thrombolytic therapy, and then primary PCI came in, and people thought, why don't we get the best of the two worlds? Why don't we give thrombolytic therapy and then take the patient straight away and do do PCI? And this is called facilitated PCI. It sounds a wonderful concept, but trials have shown that that is not the way to go as a routine with an increasing bleeding and other complications. Well, there is a lot to learn from thrombolytic therapy, and this is one of the very original studies, the ISIS-2 trial. As I'm sure you know, ISIS-1 trial was about beta blockers in MI. And this shows some very important findings. First of all, while that thrombolytic therapy reduced the mortality by 25%, aspirin independently reduced the mortality by 24%. Such a cheap, easy to administer therapy. And if you combine the both, there is an additive effect. The point here is that the effective therapy does not have to be complicated and expensive. This is very important to understand. Well, we also know that thrombolytic therapy, as in fact primary PCI, the success in terms of long-term survival is very much related of how soon the patient presents. And please, I'd like you to keep this in mind when we come and talk about out-of-hospital delay and in-hospital delay. There's a great difference between presenting and giving thrombolytic therapy within 2 hours as to 4 to 6 hours and onwards. And this success has led people to say, well, why don't we use thrombolytic therapy for non-ST-Elevation MI? It sounded also logical, but the trials like TIMI-3B trial has shown that the mortality, in fact, is slightly higher non-significant, but slightly higher than placebo. And therefore, that concept of thrombolytic therapy in non-ST elevation MI is out. And that, I go back again to basic science, which has explained this finding. If you look at the thrombus in non-ST elevation MI, in addition to other differences, it's not fibrin-rich, but rather platelet-rich. And there's also an element of embolization, plus other factors. And that, therefore, unlike the fibrin-rich, was a minimal thrombolytic therapy, non-ST elevation MI, the main thrombus was constituted of platelets. And that has made a big switch in the management of non-ST elevation MI from thrombolytic therapy to dual antiplatelet therapy. And I'm sure everybody remembers the CURE trial where clopidogrel was added to aspirin, and there's a clear benefit extending to a year. Further advances happened when we started to understand how platelets work. And we know that while platelets can be activated by many activators like adrenaline, ADP, thromboxane A2, collagen, aspirin and clopidogrel are specific to some pathways, leaving the others still activated. And it took about 12 years to discover an important receptor that is a common receptor to all these, and that's GB2B3A receptor. And it took another 10 years to find a blocker to block that receptor with great success in non-ST elevation MI. Back to primary PCI for ST elevation and back to our occlusive thrombus. Here's an example, and I hope it works because my colleagues and the audiovisual have made a great effort to make this work. Okay. This is a patient that we have received recently, and you can see very clearly that the LED is totally occluded, but in addition, there's 3-vessel disease. Okay, now I'm cheating here because the right coronary artery is injected actually after the stent, and that's what we do in primary PCI. We treat the culprit vessel and then do the other vessel. But anyway, it shows here a 3-vessel disease both on the right and left, and typically this patient would go to surgery. But in primary PCI, the rules of the game are different from that of elective patients. Here is a wire that's introduced into the ramus vessel, A to protect the ramus, and B to make it easier to negotiate the LED. And successfully, we've got the other wire, the second wire in the LED here. As you can see it moving into the LED. And then this is after, I don't think this will work, and this is the final result. It took about 27 minutes. Okay. Now, primary PCI is not superior in thrombolytic therapy across the board the same. In one end of the spectrum, the primary PCI is far superior to thrombolytic therapy, like in cardiogenic shock, large MIs, patients who already have LV dysfunction, patients who had stents before in the left system. But in the other end of the spectrum, it's not the same. And if you look at the experience of primary PCI and thrombolytic therapy, it's a very interesting one. Initially, when primary PCI is introduced as a competitor to thrombolytic therapy, the survival was better actually with thrombolytic therapy. But when you analyze this data in the earlier times, you'll find that these patients were patients who came late, all were in high-risk group, cardiogenic shock and others, and also they were treated much later than thrombolytic therapy. But as these factors have been realized, you can see that now the primary PCI has got far better mortality across the board than thrombolytic therapy. But the difference, as I said, again, is not the same in all patients. I would like to pick up diabetic patients because we see a very high rate of diabetic patients in Qatar. If you look at the difference in non-diabetic patients, it is significant, and the difference between 12.8 to 8.6. But in diabetic patients, because of the mortality with thrombolytic therapy much higher, the difference is much greater. It's about 15% difference. And to sum it all, the higher the risk of the patient, the more is the difference in benefit between in favor of primary PCI than thrombolytic therapy. Now let's come to primary PCI program in Qatar. This is done as a collaborative work between the Heart Hospital Hamad Medical Corporation and the Qatar Cardiovascular Research Center, which Professor Majdi leads. And I'd like to say that we would like to think that we are the first really, truly nationwide program because we will have one national command center, one national coordinating center of the whole country, even though Qatar is small, but still, that will be the first one. Now, there are a lot of cities around the world and multiple places, for example, in the UK that are coordinating, and one of the typical example of citywide successful protocol is that from Montreal, which was published a long time ago. Our primary PCI program is a very strong link between clinical program and a research program. Are we entitled to do primary PCI? Well, if figures speak, I'd like to present our figures. We do roughly, if you look at the number of years, the last 5 years, I think, or 6 years, the number of diagnostic and interventional procedures in Qatar have increased a great deal. This year, last year, 2012, we've done over 3,000 diagnostic procedures and over 1,400 interventional procedures. Now, if you compare to many places in the world, like, for example, there was a recent report published in JAC, which shows that surveying centers who do primary PCI in the United States, nearly half of those centers do less than 400 PCIs, not primary PCIs, PCIs per year. And many of them actually were less than 400. It is generally considered that 400 is a low volume, 800 is a high volume, and above that is obviously a super high volume. We perform 1,400. What is the overall plan? The overall plan is to have we already passed the stage of the pilot phase of 2 to 3 months, where we train our staff, discover our pitfalls, and correct and improve our protocols. Then start the clinical phase, which we've already started, shortening the delay, improving the quality of service, and regular audits. And then in research, we aim to do a database for our primary PCI, perhaps link it to international databases, and do also specific research protocols to specific areas in primary PCI. While primary PCI continues to draw attraction in research, and one of some of the areas that we will be particularly interested in is female gender and primary PCI, complete versus culprit vessel revascularization STEMI, pre-hospital GB2 blockers, and as aspiration thrombectomy, as well as the ideal antithrombotic drug choice in primary PCI. One of the important phenomena that we were taking interest in is the no reflow phenomenon, and this has been rightly labeled as the Achilles heel of primary PCI. Well, angiographically, it's defined as less than grade 2 TIMI flow at the end of the procedure, and it varies between 12, if you look at literature, it varies between 12 to 25%. However, if you look at imaging studies looking at microvascular circulation, the incidence or the prevalence of no reflow phenomenon is well about 1/3 of all patients. This is an example, and I hope it works all the way to the end. This is a patient who had a total occlusion of melody with a proximal stenosis. We initially succeeded to open the vessel, but as we proceed, the no reflow phenomenon sets in, which is a very frustrating end and takes a long time to treat it. Okay, I will put our program and what we have done under four main headings. What we have done to the ambulance service, what we have done to the emergency room in the general hospital where most patients go, what we have done to the emergency service in our heart hospital, and what we have done to the cath lab. Before I go further, I'd like to emphasize a couple of points about time delay. Now, I think everybody knows and everybody talks about door-to-balloon time. That's the time between receiving the patient to doing the first balloon dilatation, and there's a clear relationship between the delay and the survival. From 3% in less than 9 minutes mortality to 7.4, almost double, as you increase the time. And however, the time of the myocardial infarction does not start when the patient enters the hospital. It starts when the patient starts to have chest pain, and maybe even earlier, when the myocardial infarction sets in. But customarily, people talk about the door-to-balloon time, which is the in-hospital delay, and they separate also the out-of-hospital delay, and I'd like to talk about each one separately. If you look at some major registries like the National Registry of Myocardial Infarction or the GUSTO 3B, I think, or 2B, trials, you will find that there is, while the door-to-balloon time seemed to affect strongly survival, there wasn't much to be said about the out-of-hospital delay. It didn't seem to affect it as much. But if you look at some other publication, there seemed to be an intriguing and very secretive relationship between the out-of-hospital delay and the door-to-balloon time. And this is well demonstrated by a publication by Brody, where he found that the less than 90 minutes and more than 90 minutes seem to be significant when the patient actually presents early. But when the patient has already a long out-of-hospital delay, the difference that you do by shortening the door-to-balloon time is not as impressive. And therefore, it's very important, I think, to realize that these two times are not separate. They are intriguingly related. Back to our hospital, we used to be in one hospital called the Hamad General Hospital, where all patients come to the emergency room in that hospital. The cath lab is just about 40 yards away, and we had very good time. It was very easy for patients to go to the cath lab. However, about 2 years ago, we moved into a dedicated new hospital, the New Heart Hospital, and the cath lab is moved to there. Patients, however, continue to go to where you used to go. That is the General Hospital emergency room. And therefore, we have worked into 3 phases of speeding up patients' transfer. Phase one is to speed up the transfer of patients from the Hamad General Hospital to our hospital, and therefore the cath lab. And the other thing, which is phase 2, and that we have already finished this phase, and that is directing all patients who come from ambulance or primary health centers directly to the heart hospital and not go to the general hospital. It's our aim that this should be the case for all the hospitals in Doha. If they have a STEMI, recognized STEMI or suspected STEMI, the patient should come to the heart hospital, not the general hospital. Our target, as with everybody else, to achieve 90 minutes, but we aim to, in very short time, to move to less than 60 minutes and maybe even further. To do that, we are training the staff, we're improving our protocols, and we have a core staff to be staying 24 hours in-house. What have we done in steps? Well, before, patients who arrive to the emergency room are mixed among many other patients who have atypical chest pain, anxiety, or any other thing. Now we have started to tag patients with STEMI to be on top of the list, and we have to have an ECG within 10 minutes, and the ECG must be read within 5 minutes. To make life also faster, we have put a package in the emergency room which includes everything that patient needs, from the IV lines to the tubes to everything, and we will not wait for the results of the blood test before the patient is transferred. Also, the forms, which take quite a long time, especially if you are experienced with a JCI, it takes a long time to fill forms. The forms are pre-filled and read to the patient to sign his consent. Before also, the patients who transfer STEMI patients are one of many ambulances that can transfer any other patient with stomach pain, for example. But now we have National Command Center, which will direct the nearest ambulance to the patient, and we have now GPS tracking system that will track the position of every ambulance to find out where is the nearest ambulance to the patient, and also track the arrival of that ambulance to the heart hospital. We have also made an agreement now with the Ministry of Internal Affairs, and now we have the helicopter also at our disposal to transfer STEMI patients from remote and inaccessible areas. Therefore, it looks something like this now. If patients has chest pain, we're working towards transferring these patients directly to the heart hospital and therefore the cath lab. To do that, we have put in a program of national program of awareness to improve the knowledge and the awareness of patients and the communities and physicians and the ambulance services about the importance of time in STEMI. We have also instituted now, about 3 months ago, the wireless ECG transfer. So ECGs, 12-lead ECGs, will be transferred from the ambulance. Immediately they're taken on the patient directly to the heart hospital. And also, only last week, we have put the software to transfer it directly to the smartphone of the consultant. Therefore, the consultant and the emergency room will know exactly what is the patient coming, and if it's a STEMI patient, the protocols are set in. Okay, this is putting it all together. Patient having chest pain, transferred directly to the cath lab, and if they happen to go to the general hospital, we have now phase 1, which is rapid transfer from Hamad General Hospital to the cath lab in the heart hospital. The wireless ECG transfer is to the cath lab and to the consultant on call. And with this way, we have linked the out-of-hospital as well as the in-hospital delays in one, in trying to reduce both the out-of-hospital as well as the in-hospital. We are auditing every phase of the transfer of all the patients, and this is our results. When we were in Hamad Hospital up to December 2011, we achieved 78 minutes of door-to-balloon time. When we transferred to the heart hospital, because of the chaos you can imagine, we had the delay was greater. It became 106, and that was in the first 6 months of 2012. But I'm very glad to now report that in the last 6 months, we have achieved 72 minutes, and therefore now we have passed the first target of 9 minutes, and we're hoping to catch up with the second target of 60 minutes. And once we reach there, I think we'll set the third target of maybe 40 or 30 minutes. In conclusion, Mr. Chairman, ladies and gentlemen, performing primary PCI in suitable patients significantly improves morbidity and mortality. Qatar primary PCI program is a combined clinical as well as a research program to provide a 24/7 primary PCI service. It's a collaborative project between the Heart Hospital and the Qatar Cardiovascular Research Center of Qatar Foundation, Professor Majdi Yaqub. It will be truly the first nationwide program that will have one single national command and coordinate center. So results so far confirm that we are achieving the international standards, and that has not been possible without a great collaboration and a lot of work of all of my colleagues, from consultants and specialists and nurses, administration, emergency rooms, as well as the ambulance staff. Thank you very much for your attention.
Thank you, Dr. Gehani. We may have some questions from the floor. It is open for discussion. Dr. Hussein.
A justifiable delay. It was mentioned in one of the slides.
Happened when we were transferring from the Hamad General Hospital to the Heart Hospital. During that period of time, there was protocols that we have not put in to indicate to the emergency service. This is number one. Number two, at that point in time, it was the prerogative of only the cardiologist to activate the cath lab. The emergency physician, if he discovers STEMI, he has to speak to the cardiologist. The cardiologist has to speak to his consultant, and then that was, according to the old protocol, justifiable. But we have removed all that. So what was justifiable then is not justifiable anymore.
I have a question, and sorry, after you. Dr. Gehani, incredible effort, what you have done, and now you're ready to go. The question I have is, what about awareness campaign? I thought you were interested in that. Can you tell us what you have done?
Yeah. Now, the awareness campaign, I think, to have to be a massive campaign, frankly, to be effective. Individual efforts like an interview with a consultant once every 6 months or something will not do anything. And therefore, while we're doing our efforts at this moment in time, we're concentrating on our efforts with physicians in the community and the ambulance service. Next will be the public campaign. And for public campaign, we have to set budgets, means, we have to set up, it has to be multidisciplinary. I think the Ministry of Information has to be with us, the TV has to be with us, Al Jazeera, I think, has to be with us. So to really realize a proper public awareness program, it needs more arrangements.
What about that picture which we have seen from Dr. DiMario? How would that go down in the local culture?
If you put that picture without words, I think half the people won't understand what you mean. In Qatar, I'm talking. If you put that belt, picture of the belt, they won't
Yeah.
understand. I
And
think
they need-
you may have to add a couple of words to it. Then it will be understood.
Okay, but you think it's a good idea?
Yes, I think it's a good idea, but in
because-
Qatar you have to add a couple of words.
It's so clear anyway, and might have an effect on cutting
I think
that
yeah.
interval from pain,
Yes.
which Professor Antonucci was talking about.
I,
as well.
I think Professor DiMario pointed out that there are definitely differences between nations. And because, for example, the programs on the TV in the UK or in Europe quite often involve describing chest pain and this belt and all that, this picture immediately sets in mind of a European all these information. But in Qatar, I don't think they have that information. And therefore, the picture is great. I think it's very, very impressive and descriptive. But I think in Qatar it has to have a couple of words. And not only a couple of words, it has to be multilingual as well.
Okay. I mean, in the UK, there was something on the radio, Professor DiMario, where on Classic FM, they would say, very subtle, somebody would say, I thought it was indigestion. Now I regret it. Full stop. Nothing. I mean, nothing of it. Do you think something like that?
Yes.
Do people listen to the radio? And what do you think?
I think, now I'm talking from our community, picture alone may not give the full
picture
message with some words.
With heart attack.
Something like this, yes.
Heart attack
Yes.
skill or something, or avoid
Or
heart attack.
indigestion can be a heart attack. Yes,
Yeah.
yes, definitely.
Dr. Gehani, Gehani?
Question for Professor DiMario and Dr. Antonucci. Professor Antonucci, whom I can't see, and Professor Antonucci. So, all the algorithms shown on both the 2011 ESC guidelines and the 2013 STEMI guidelines that have just been released focus on the 120-minute delay from first medical contact, or you might argue from onset of symptoms, to thrombolytic therapy, or as a matter of fact, to primary PCI. And say if you cannot achieve a transfer to a primary PCI facility and a door-to-balloon time of 120 minutes, go for thrombolytic therapy. What about relative delay? Because we always assume that streptokinase would be given immediately upon transfer. And that was addressed in a recent paper in Nature Reviews Cardiology. The delays to deliver streptokinase seem to climb well above the 30-minute period that is usually stated in these guidelines. So do we still stick to 120 minutes, or do we take into account the possible or potential delay to administer a thrombolytic therapy?
As you pointed out, there are two different delays. One is to deliver a balloon angioplasty, and you accept an extra delay up to 2 hours, and the other is to deliver thrombolysis, and you want to have it done as soon as possible, and 30 minutes is considered the absolute maximum. I may agree that, and that's why I strongly reiterate the concept that even if primary angioplasty is the optimal therapy and the goal, you should not forget to have a proper service for thrombolytics, especially if you are in hospital without a primary PCI facility. Very occasionally you may have all the cath lab full and be in a situation you are forced to do it. And I confess, in my hospital, I have no idea where those damn thrombolytics are, because I think the last was for a pulmonary embolism 1 month ago. I think that the under 20 minutes is the what came up as the official cutoff point, and is hard to deny that this is what we
Your
should
time is
apply.
up.
So we let David
It's a big
continue.
statement, man.
Can I ask a question?
Okay. So,
My view is completely imperfect, not completely different, since with the new stent, with the new adjunctive therapy, you have the possibility to overcome the problem related to delay. And I think that it's not possible that the cath lab may deny reperfusion because there is a procedure on board. This should not be considered. And if we discuss a lot on 30 minutes, 60 minutes, 100 minutes, etc., this is very, very marginal, because the goal is to reach the effective reperfusion at the microvessel network, and this can be reached also for very late placenta cases. Thus, if you have a thrombolysis facility, that means a time to needle of less than 20 minutes, if I remember well, you may put into the patient the fibrinolytic therapy. But otherwise, if you need 45 minutes to put the fibrinolytic treatment, I think that it's more convenient to go with this 45 minutes to the primary PCI facility center.
Dr. Galal Said.
I would like to make a comment on what Sir Mahdi said and then ask a question. I think in Qatar, the public awareness is it's very easy to do, and actually they succeeded in making campaign against cigarette smoking, which we are unable to do in Egypt. And I would like to ask Abdurrazzak, where is the consultant? Does he sleep in the hospital? But with this big volume, do you call him at home? And sometimes the traffic in Qatar is very difficult. Do you keep the consultant at home or not? Because for such a program to succeed, the consultant must stay overnight.
Yeah, if I go back to so one of the slides, if you look, the core staff, and the core staff involves the consultant cardiologist, the specialist cardiologist, specialist anesthesia, 2 nurses and a technician. These are called the core staff. And these, in the primary PCI program, stay in the hospital. Now, not exactly in the hospital because we don't have enough rooms. There is the Hamad City compound, which, if you remember the Olympics, the Asian Olympics a couple of years ago was in Qatar. One building, several buildings, in fact, have been given to Hamad Medical Corporation. One of them is for the biobank, building 22, and one of the floors in the hotel is given to primary PCI. So they will be within, I think, less than a mile away. It will come very quick. I agree with you. Traffic. Now, traffic after midnight is not as bad, but during day hours and up to midnight, it can be bad.
And in most cities around the world, I mean, the consultants do not stay in the hospital,
No.
to my knowledge, because of what Dr. Gehani has just said. During the day, they are there, and during the night, the traffic is not too bad. And importantly, they will know when the ambulance or the patient has alerted them, and the patient is on his way. I don't know how long is that period from the patient alerting the ambulance, and how long does the ambulance take to arrive. And in Harefield, where you showed that the door to balloon was 20 minutes, they do not live in, but the ambulance rings the consultant and the catheter lab, and they all walk in at the same time.
Now, we have voluntarily taken the decision, at least for the time being, that we will stay in as part of the program. We want to achieve less than 60 minutes, and we want to achieve less than 30 minutes. Now, I don't know whether the less than 60 minutes makes any difference. I don't know. But clearly, the shorter, especially in high-risk patients. So for now, we have taken the voluntary decision to stay in. If in future we show that that's not necessary, maybe we will be pleased to change it.